Okay, so good evening to everyone. Thank you once again for joining another session of ours. Today we have a very special topic to be taken by one of my seniors, that is Shreesha. So it's on that topic that I think most of you outside the big centers in India might not have even heard of, which is retrograde intubation. So this is not something that we usually do. Maybe we'll do it a handful of times a year. And so I thought it would be a good idea to have a session on exactly how you do this and what kind of patients you even consider doing something like this. So without further delay, I'll give it over to Dr. Srisha sir to start the session.
Thank you, Dr. Mehul. Good evening, everyone. I am Dr. Shreesha, Senior Resident in the Emergency Medicine Department, AIIMS, New Delhi. We all heard of regular intubations, which happens every day in our day-to-day practice. However, retrograde intubation, as the name suggests, is somewhat different from the regular intubation in a way that it's partly surgical technique and partly part like similar to the regular intubation. Uh, in opposition to the regular intubation, here we introduce a guide wire through the neck so that the guide wire allows our access for us to pass the uh, normal endotracheal tube. It was first described in 1960 by Butler and Cirillo, and later initially it was the epidural catheter in the anesthesia set which was used as the guide wire, and the epidural catheter was inserted through the cricothyroid membrane. Now there are uh, this regular retrograde intubation sets which are commercially prepared and available. However, if we do not have those, we can have our own in-house set for this purpose. So the indications being, uh, usually we do not use this particular uh, type of technique. However, if there is severe trauma like maxillofacial trauma or any suspected cervical spine fractures where we are unable to move the neck, or there are mouth tumors wherein we are unable to insert the regular laryngoscope, or there is restricted mouth opening, or restricted neck mobility, such as in arthritis or dystrophies, or as a part of failed airway techniques wherein we have attempted to do regular intubation, and either it's a grade 4 view and we are unable to pass the uh, endotracheal tube, or we have secured a laryngeal mask airway after the failed airway, and we are further attempting to secure a definitive airway access. Contraindications, anterior neck mass and or infections or any malignancy over the puncture site over the cricothyroid membrane is a absolute contraindication. It also cannot be used in a cannot ventilate, cannot oxygenate situation wherein surgical airway, the standard cricothyroidotomy should always be used. And if you are if you are unfamiliar with the equipment or the technique, again, it's a relative contraindication. Richmond also says limited mouth opening to be a contraindication, but however, as we will see later on, it's not exactly a contraindication. So in addition to our standard intubation equipment, which we usually use, in addition to this, we need gauze and betadine to clean the skin, and we need a syringe with saline attached to a 18 or a 16 gauge needle or a angiocatheter. In addition to this, we need a spring guide wire which is 68 to 80 centimeter in length at least. This can be used from the central line set that we usually have, or you can use amplitude stiff guide wire or a thermo guide wire, which is available separately in the market. So the most important part is the technique. Once we have established that we need to proceed with the retrograde intubation, get the kit and prepare the skin. This is usually done by using chlorhexidine or betadine. Then stabilization of larynx, similar to performing a cricothyroidotomy by a laryngeal handshake maneuver, is of paramount importance. Then using the needle attached to the syringe and saline, we puncture the cricothyroid membrane, keeping the beveled end of the needle facing cranially, as given in the image. Later, we pass the guide wire through the, once there is aspiration, we pass the guide air on aspiration, we pass the guide wire through the needle, and once this guide wire exits either through the nose or the mouth, or if you are unable, if the guide wire spontaneously doesn't come out of the mouth or the nose, you can use a laryngoscope and a Megile's forceps to visualize the guide wire in the oral or nasal cavity or in the oropharyngeal cavity. Once you get hold of the other end of the guide wire, you railroad the ET tube through the Murphy side of the endotracheal tube. Once you pass the endotracheal tube through the Murphy side, once you hit resistance, that means now the endotracheal tube has crossed the vocal cord. And since you have passed the endotracheal tube through the Murphy side, this, in addition to the length of the ET tube, around 1.5 to 2 centimeter will be ahead beyond the cricothyroid membrane. So now we are like really sure that the endotracheal tube is in the trachea. Now you remove the guide wire through the proximal end and further advance the ET tube, and after this you confirm the position using the standard technique using EtCO2 and 5-point auscultation. So what could be the complications? Complications is mainly hypoxia due to prolonged intubation time. This usually occurs if you do not choose the patient, do not choose the right patient for this procedure. In a simulated scenario, it was shown that this procedure in an experienced hands take around 70 to 75 seconds on average. However, if you are inexperienced and unfamiliar with the technique, which is a relative contraindication, this might actually take around 2 to 3 minutes at least. Then if you have punctured the posterior wall of the trachea and gone through the esophagus, this can also result in a esophageal intubation. And retention of guide wire and breakage of guide wire has also been described. In a case which was not case report, it was shown that there was in a regular retrograde intubation, the guide wire actually broke and the patient presented with dysphagia after 2 years. And at that time, it was detected that a piece of guide wire was still in the neck tissues. Also, subcutaneous emphysema and pneumothorax can occur, injury to laryngotracheal structures or esophagus. However, this is not a serious complications as compared to surgical cricothyroidotomy or surgical tracheostomy, because we are just puncturing it with the needle and it usually spontaneously heals on its own. Rarely, tracheoesophageal fistula as a result of these injuries can also occur, and skin and soft tissue infection can also occur. And aftercare is similar to regular ventilator care bundles. And special mention is you need to keep on monitoring for puncture site infection and make sure that there is no infection. So this was the actual case in which we performed a retrograde intubation. This was the second retrograde intubation that we performed. A 65-year-old male diabetic and hypertensive patient with severe kyphosis. He had malignant MCI infarct about 15 days ago and was discharged 2 days ago from our own hospital. He had presented shortness of breath for about 2 hours after giving oral feeds. So this was a clear-cut case of aspiration. So this was the not the real patient, but this was almost how he looked like. So on presentation, his airway was compromised. His saturation was 70% on room air with a respiratory rate of 28 cycles per minute and bilateral coarse crept heard on auscultation. His heart rate was around 140 beats per minute with blood pressures 82 upon 48, and GCS of E1, B1, and M1. So this was obviously a case of difficult airway because the anatomical difficulties being severe kyphosis, the patient was unable to lie supine. There were no neck movements. We were unable to flex or extend the neck in any way. There was limited mouth opening limited to one red, and the cricothyroid membrane was below the sternal notch. So, what are the possible technique that we can use to intubate this patient? I think someone can answer us.
Anyone can unmute themselves and answer.
Uh, just like a open house.
Okay, Dr. Vishnu says surgical crike.
Sorry.
Dr. Vishnu was typed out in the chat box surgical crike. He like to type.
So,
Uh,
surgical crack should should be ideally done in this patient, but the problem here was the cricothyroid membrane was below the sternal notch, and since the patient was sort of gasping during deep inspirations, the cricothyroid membrane was just like popping up uh, above the sternal notch. So cricothyroidotomy was again not really easy in this patient. So with this anatomical difficulties, we also had hypotension, hypoxemia, and acidosis. So all the three hop killers. So this was like technically the most challenging anatomical and physiologically difficult airway that we faced. And this was the actual patient. So this was post intubation. You can see that to in order to maintain position of the patient, we had kept a saline like filled box below the patient's legs. Despite that, you can see the due to the limited neck mobility, the head was not exactly touching the bed. So again, we had also sort of give a had to give a ramped up position in order to maintain this particular position, so that the patient could sort of lie supine for us to intubate him. So what actually was done in this patient was initially we were not sure how to proceed with this particular airway. So we went ahead with blind nasotracheal intubation. This was given two attempts. Once we passed the tube into the one nares and inflated the cuff, which was not in the trachea, and with the inflated cuff in C2, we passed the second tube using the second nares, and somehow again it was not in the trachea. And this at this point we thought of retrograde intubation. However, uh, actually during this particular intubation, I somehow managed to puncture the esophagus, and it was undetected. And when we passed the tube, it was found to be in esophagus, and this particular attempt failed. So at this point, uh, we thought of attempting video laryngoscopy, and we thought giving succinylcholine would probably help us by improving the mouth opening somehow. But again, as we saw in this case, this attempt failed, and we had to go ahead with the second retrograde intubation attempt. But at this point, we had given succinylcholine, and as I said, in this particular case, the cricothyroid membrane was below the sternal notch, and as we had given paralytic, we could not localize the cricothyroid membrane at this point, and all attempts to puncture the cricothyroid membrane failed, and it was sort of hitting the laryngeal, thyroid cartilage. And we waited for about 5 to 10 minutes for the succinylcholine to wear off, and we started bagging the patient during the meantime. And once the patient started having spontaneous respiration, we gave a third attempt at retrograde intubation, and this was successful. So, what this was the actual patient. This was actually the first attempt which was made. In this video, I had already made the uh, cricothyroid puncture, and we this in this you can see me passing the guide wire. So this was not exactly a sterile technique. So once the guide wire came out of the mouth, we used the Murphy's eye of the endotracheal tube. Murphy's eye of the endotracheal tube to pass the guide wire. And we had to maneuver to in order to pass the endotracheal tube as seen. So the in this scenario, the best technique obviously would be to use fiber optic laryngoscope or a fiber optic bronchoscope. But however, at that time we didn't have flexible fiber optic bronchoscopy in our emergency, and after this particular situation, we uh, actually convinced the department to get one. So in case you have a flexible fiber optic bronchoscope, that would be the best way to go in these cases. But many places in this particular fiber optic bronchoscope is a costly thing and it's not available. So it's always better to know how to proceed and how to conduct retrograde intubation. So that's it from my side. Any questions?
Um, so I think somebody is asking why didn't you go for focus guided surgical cry? I think the problem was here
So,
was the membrane was not at all actually in the neck. Actually, it was.
the thing is, in this, the patient was lean and thin, and we could actually feel the cricothyroid membrane and all the neck structures like very prominently and very easily. So it was not that we could not visualize the cricothyroid membrane. We could actually palpate the lower border. Sorry, we couldn't actually palpate the lower border of the thyroid cartilage, which was below the sternal notch, because of the severe neck flexion as visualized as seen in the image. So okay. So in this case, this was the sternal notch, and because as you see, there was severe neck flexion, and it was sort of in a fixed position. You could not even flex it or extend it in order to expose the laryngeal cartilages more. So it was technically not possible for us to perform a surgical break. And since this patient had sort of a cannot ventilate, cannot oxygenate situation, retrograde intubation is a contraindication in this patient. And if possible, surgical click should have been performed.
So I think a few of our other doubts is that we once How do you make sure that while you're pulling out the guide wire that you don't pull out the tube also?
So that again is a possibility that you pull out the guide wire, but the very purpose of using the Murphy's eye is this. Once you pass the guide wire through the Murphy's eye, you know that that endotracheal tube is additionally 1.5 to 2 centimeters distally as compared to the cricothyroid membrane. So since about vocal cord is present about 1 to 2 centimeters above the cricothyroid membrane, that is at the level of almost the Adam's apple. Overall, we'll get a leverage of around 3 to 4 maybe 3 to 4 centimeters if we perform the procedure right. So make sure that you do not use jerky rapid movements and use smooth movements to in order to remove the guide wire. However, that's a real possibility that you might dislodge the endotracheal tube while trying to remove the guide wire.
So I think there are some other videos on the internet about where this procedure is done in other groups of patients. Like there's a video of I think it's on Instagram or something about it showed that this was considered in a patient with upper GI bleed and the airway. And on the TV show, I think they did one on a severe asthma case. They were not able to. So
So please remember, this is sort of relatively uh, not should not be used in a crash airway where you cannot oxygenate or cannot ventilate. So in all of these situations, go ahead with the surgical airway, go ahead with a surgical cricothyrotomy. However, if the airway is your airway is sort of secure for the moment, there is no active aspiration. You are able to adequately ventilate the patient and you are able to adequately oxygenate the patient. In this particular scenario, wherein you have around at least 2 to 3 minutes before you secure a definitive airway, this will be the best subset of patients wherein you can go ahead with the procedure so that it's sort of less invasive as compared to a surgical airway. And please do not perform this in cannot ventilate and cannot oxygenate situations.
yeah, I think the main point here is that you should not try this in patients who are having like a crash airway situation.
Yeah.
Where you really don't have any time left, then you obviously go for more of the traditional options that we are more familiar with. So anybody else has anything they would like to ask, or you can just unmute yourself and ask, or you can just type it out in the chat box.